Hello, my name is Dr. Andrea Kostler, and I am Associate Professor of Ophthalmology at the Stanford University School of Medicine, and I'm the Director of Oculofacial Plastic and Reconstructive Surgery and Orbital Oncology at the Byers Eye Institute at Stanford in California. It's my pleasure to welcome you to this discussion on thyroid eye disease, an evolving continuum of care. And it is my pleasure to have an international panel with two friends and colleagues. The first is Dr. Mario Salvi. He is the head of the Center of Graves' Orbitopathy in Milan, Italy, and a consultant endocrinologist at the Department of Clinical and Community Sciences at the University of Milan. And I've had an opportunity to visit Dr. Salvi at the University of Milan, and I'm so excited to have him with us today. Next, we have Dr. Edsel Ng. He is professor and chair of ophthalmology and visual sciences at the University of Alberta, and also professor of ophthalmology at the University of Toronto, Canada. And again, another friend and expert in thyroid eye disease. So excited to have both of them here with us today. We're going to start our first educational module, understanding the mechanism of thyroid eye disease and who is at risk. First, let's get into the pathophysiology of the disease. And looking at this slide, you can see it is actually quite complex. But thyroid eye disease is characterized by inflammation, volume expansion, and remodeling of the orbital and periorbital tissues, with the key player of this disease being the orbital fibroblast. The orbital fibroblast has antigens on its cell membrane, the TSH receptor and the IGF-1 receptor, that co-localize together. When our body recognizes these antigens as foreign, it can start this inflammatory response where we can have adipocyte proliferation, myofibroblast proliferation, orbital fibroblast proliferation, and the secretion of cytokines and hyaluronan and other inflammatory products that can result in orbital soft tissue expansion, bulging of the eyes, double vision, and even loss of vision. It has been said that the natural history of thyroid eye disease involves an active inflammatory phase that can last anywhere from 6 months to up to 5 years. Typically, patients will have pain, redness, and swelling that will progress over time. And patients will eventually plateau into a static phase where the inflammation subsides, and eventually they'll move into this inactive phase where this is characterized by oftentimes fibrosis, and the sequela of the disease persists, although the inflammation subsides. It's been quoted that up to 16% of patients can have reactivation of disease long after the patient has moved into the inactive phase of the disease. Now, there are many treatment options for thyroid eye disease, and we're not going to get into it too deeply here, but I would be remiss not to mention that when patients have mild disease, we want to treat them conservatively by lubricating their ocular surface and minimizing risk factors for progression of disease. When patients have moderate to severe disease, there are many medical therapies that have been reported to be effective for this disease, including steroids, radiation, and biologics. And then finally, sight-threatening disease is an emergency, and these patients can be treated with high-dose steroids or surgery or other medical therapies. When patients have inactive disease, typically we're treating these patients with surgical rehabilitation. However, a phase 4 study did demonstrate that teprotumumab can be effective in proptosis reduction in these patients as well. We're going to move into the panel discussion, and I'm going to talk to my esteemed colleagues here, Dr. Salvi and Dr. Ng. I'm going to throw the first question over to you, Mario. I'd love to hear a little bit about the link between Graves' disease and thyroid eye disease.
Well, certainly thyroid eye disease is associated to Graves' disease because most patients have an underlying thyroid disease, which is hyperthyroidism, and this is caused by these TSH receptor-directed antibodies, which produce hyperthyroidism and do have some stimulation also of the fibroblasting of the orbit. So the link is very, very close, although we do not understand very well everything about this link. We know, for example, that there are some patients who do not have any eye sign despite having maybe an ongoing thyroid eye disease, a Graves' hyperthyroidism, which is even, sometimes not easy to control with therapy. And we also do have some patients who have thyroid eye disease associated to another form of autoimmune thyroid disorder, which is Hashimoto's thyroiditis, which behaves certainly different since it's mostly a hypothyroid disease. So the link is probably related to some immune mechanism, certainly driven in a good part by the TSH receptor antibodies, but some unknowns that still need to be studied.
Certainly, there are many unknowns still with thyroid eye disease, but we do know that thyroid eye disease is the most common extraocular or extrathyroidal manifestation of Graves' disease, but certainly not everybody develops the eye findings when they have a thyroid dysfunction. I'm going to send the next question to you, Ed. Tell us a little bit about the main risk factors for developing thyroid eye disease, and are any of these risk factors modifiable?
Well, thanks, Andrea. So cigarette smoking is the most important modifiable risk factor, but things like thyroid dysfunction, both hyper and hypothyroidism, elevated thyrotropin receptor antibodies, and radioactive iodine therapy not accompanied by low-dose steroid prophylaxis, family history, increasing age, and female gender are associated more with thyroid-associated orbitopathy, but I do see the worst disease in male smokers in my practice. An interesting development in the last 5 to 10 years is in MS treatment for chronic relapsing MS. The drug alemtuzumab can cause apparently thyroid-associated orbitopathy in up to 30% of patients.
Very interesting, and we know how important it is for us to work with our endocrinology colleagues, as they're oftentimes seeing these patients very early in disease, and they can help us to manage some of the systemic conditions that can put our patients at risk. So Mario, I'm going to throw it over to you. What main risk factors are you recognizing for thyroid eye disease, and are they modifiable, and what are you doing to decrease their risk?
Well, the modifiable risk factors are certainly thyroid dysfunction. I mean, we know that controlling, normalizing thyroid function is important for the progression of the disease. So avoiding especially hyperthyroidism or even hypothyroid. So monitoring, close monitoring of thyroid function is essential. Other modifiable risk factor is if you are convincing enough to as patient to stop or refrain from smoking. Certainly we know that smokers have a more, I would say, rebel thyroid eye disease, in the sense that they're more resistant to treatment, and they certainly are more prone to develop more severe forms. Other risk factors that are not modifiable are certainly the age and sex. We know that the presentation of diseases changes with age, and for example, the proportion of female to male tends to become less strong. I mean, usually the females have prevailing disease compared to male, but this difference tends to be less strong with advancing age, especially middle age. So, and this we can't do anything, unfortunately, about. But certainly, one I think is important to do in terms of risk factor is in a way to prevent the disease, is really to suggest patients to report very, very quickly whatever eye symptoms they have, because that allows us to come in very strongly. You know, we know that mild disease, you mentioned before, is something usually treated with conservative measures, but there are studies who have shown that some supplementation with selenium may help in reducing the progression of the disease.
Yeah, I totally agree with that. And in my patients that have mild disease, I think there's a lot of education that's important in assessing for their risk factors and working with endocrinology and our other colleagues to monitor their thyroid dysfunction and to talk to them about smoking cessation and other things like checking their vitamin D, seeing if they need selenium supplementation, and evaluating them for things like diabetes or having high cholesterol, sleep apnea, et cetera. There's a lot of these risk factors, and we try to help to minimize those modifiable ones. And then finally, we have one more question, and Mario, I'm going to stick with you on this one. Is there any correlation between the level of autoantibodies and thyroid eye disease activity and severity?
Well, certainly there is data, evidence that both activity and severity do relate to higher titers of TSH receptor antibodies. Whether they're totally pathogenic or not, we discussed before, we don't really know for sure, but we do know that more severe forms of hyperthyroidism do present with thyroid eye disease, and usually in more severe forms. And I think this is important in terms of especially a diagnosis, if patients do have Graves' hyperthyroidism, and they have elevated titer of TSH receptor antibodies, but no eye signs. I think these are the patients who have to be more closely monitored because they are more prone, certainly, to develop the eye disease later on.
Great. And Ed, what's your opinion on that?
Thyroid-associated orbitopathy is a clinical diagnosis guided by lab tests. So things like thyroid-stimulating immunoglobulin, thyroid peroxidase antibody, thyroglobulin antibody, and serum IGF-1 levels at present, they just don't seem consistent. But the future with blood, tear, and urine biomarkers, maybe we'll find some magic predictor for the clinical course of thyroid-associated orbitopathy.
So we can allow our labs, like our thyroid-stimulating immunoglobulin, to guide us. And I do agree that sometimes there can be a correlation of activity and severity, but yet it can be unreliable. It's been wonderful talking about this with you and discussing how the pathophysiology of thyroid eye disease and how we can best identify thyroid eye disease in our patients. This concludes the educational module, and it's been wonderful talking with you today. In the second educational module, we will be discussing the clinical presentation of thyroid eye disease. We'll talk about what the signs and symptoms are for thyroid eye disease. First, let me just get into some of the common signs and symptoms. Most patients with thyroid eye disease are going to first present with ocular surface signs and symptoms, and so they may present to their ophthalmologist. We know that about 65 to 85% of patients with thyroid eye disease also have dry eye symptoms, and this can include things like pain, redness, tearing, burning. These patients oftentimes have inflammation in their lacrimal gland, and this can affect their tear production. They can also have inflammation on the conjunctiva above their cornea, and we call that superior limbic keratoconjunctivitis. Oftentimes, patients can have difficulty with eyelid closure or blinking, which can cause their cornea to be exposed. And if very severe, this could result in a scratch of the cornea, an infection, even a corneal ulcer or perforation. Another extremely common thing that we see in our patients is eyelid retraction. This occurs in up to 90% of patients that have thyroid eye disease, and it's very aesthetically bothersome. Patients can look like they're staring. The white sclera is exposed. When they try to look down, the eyelid can lag behind, and this can impact their ability to blink or close their eyes, and then this can lead to pain of the ocular surface. Another common presenting sign or symptom is proptosis. Proptosis is when there is hypertrophy of fat or muscle or even just edema and fluid, which can push the globe forward. This can cause the cornea to be exposed. It can cause increased pressure inside the eye, and it can be aesthetically bothersome and even disfiguring. Another very common presenting sign is double vision. This occurs in about 50% of our patients. The extraocular muscles can get very swollen and enlarged, and this can result in difficulty in moving the eyes, and patients will experience double vision or diplopia. And then later in the course of the disease, the fluid and inflammation can transition into scar tissue and fibrosis. And again, these patients can have double vision, which can be very challenging to treat, both medically and surgically. And then when all of these things are combined and the muscles enlarge and the fluid expands the orbital soft tissues, the optic nerve can be compressed or stretched. And this can result in vision loss. This is one of the more severe and concerning final signs and symptoms of thyroid eye disease. Another thing that can happen is the cornea can be so exposed that the cornea can break down, also leading to decreased vision. So now that we've talked a little bit about these signs and symptoms and things that we really want to monitor in our patients in clinic, let's talk a little bit about the burden of the disease and these signs and symptoms and how we can recognize them so that we can properly diagnose this disease. And so I'm going to turn back to my friends here, my esteemed panel, Ed and Mario. And we have about 4 questions here. Let's get into the first one. What are the key first signs of thyroid eye disease that can prompt early detection? And I'm going to throw this one to Mario Because as an endocrinologist, you are seeing these patients that have Graves' disease and thyroid dysfunction, and you're treating them very regularly in your clinic. How do you recognize when patients have kind of developed the eye manifestations of this autoimmune thyroid disease?
Thank you, Andrea. Well, as you mentioned, the presentation can be very heterogeneous, but the most common clinical signs are lid retraction and edema, which is usually something appearing very, very early. And it is often accompanied by the proptosis, which, this protrusion of the eyeball forward is really something that the patient tend to realize, to notice and report very, very easily. And often the first sign is also something related to some diplopia that appears maybe in some awkward position of the head, not necessarily in the primary position, but patients sometimes complain in the morning, they wake up for the next 10 minutes, 15 minutes until they get up, they see double. These are very early signs that we usually, we have to pay attention to these signs because often this is really the early signs, and this might be the time that you really start monitoring and to decide for how to approach the treatment, because we know that this disease is sometimes rapidly progressive, and the early you diagnose the disease, more tools you have, the more tools you have to treat the disease.
That's such a keen insight. So first thing in the morning, worsening symptoms, particularly swelling and double vision. I completely agree with that. Ed, I'm gonna give you the second question, and you can certainly touch on the first question as well. What common eyelid changes do you see in patients with thyroid eye disease, and how do these eyelid changes relate to the underlying mechanism of thyroid eye disease?
So as we all know, lid retraction, both the upper lid and the lower lid, is the most common sign, eyelid sign in thyroid-associated orbitopathy. The mechanisms of upper lid retraction, sometimes it could be the sympathetic overdrive in the from the hyperthyroidism. Some people also talk about fibrosis of the superior rectus and the levator complex. And also, if the patient has inferior rectus restriction, that may be causing some of the upper lid retraction. Many of the patients, they have the lid retraction more on the temporal side. They get a bit of a temporal flare. And we all talked about the lid edema. That's especially more prominent in the morning due to just dependency. And as you mentioned, with the glycosaminoglycans that you get in orbitopathy, they imbibe a huge osmotic load, and they make the cells swell up. There may be venous congestion from the increased orbital volume, also causing a lid edema.
I completely agree. I also have my patients, I have many patients that complain that their eyelid crease has changed, or there's an asymmetry in the eyelid crease, or maybe they think one eye is droopier than the other because the retracted eyelid is so mild, they think it's the opposite eyelid that's the problem. So really listening to our patients and really understanding what they're complaining of sometimes can help us to diagnose this disease very early. Let's move on to the third question here. What signs and symptoms indicate a thyroid eye disease medical emergency? And I'm gonna throw this one over to you, Mario. How do you tell when a patient really needs to be treated emergently for some type of sight-threatening disease?
Well, sight-threatening disease sometimes is very subtle, and it's not really something so easy to diagnose. But patients often help you, because when you ask them if they had, their complaints sometimes are having blurred vision. So then you go on, and usually what we ask is, do you see the same red that you used to see before? Is the red color faded? This is one sign that is very, I would say, very sensitive to that. And patients are able to detect the difference in that. And the other thing is that often they complain because they have pain really behind their eyes when they raise their eyes. So in the upward place, they really complain about pain. These are very these are symptoms that have to be really looked into. They're very suggestive of something possible. In terms of sign, I'm very lucky. I work in a joint clinic with my colleague ophthalmologist. So when we perceive that there is something like that, then the whole workup is done by the ophthalmologist. There's certainly checking vision, performing CT scan or MRI of the orbit to see if there is some sort of compression of the optic nerve, but also performing visual field examination. These are all things that help. And we do use also color testing for screening, and they tend to be very sensitive too. So there are ways to be, the most important thing is to take your time with these patients, because this is something that doesn't necessarily appear so clear, like having the classic inflammatory thyroid eye disease with edema and proptosis. Some of these patients do not really have a relevant proptosis. So even that has to be looked into with more care.
That's such a great insight from a non-ophthalmologist, that you are able to identify potential sight-threatening disease based on color vision. We know that color vision is one of the most sensitive and earliest signs of optic nerve compression or damage. So it's really nice to hear from a non-ophthalmologist that anybody can at least assess for this concern and then quickly refer to an ophthalmologist for a complete workup. And Ed, if you can maybe add to that, and what types of things do you do to work this up?
Well, one thing I neglected to talk about before in terms of the signs is the amount of asymmetry that you can have. So thyroid-associated retinopathy is usually a bilateral process, but it can be very, very asymmetric. I think you touched on that when you're talking about the lid crease stuff. In terms of the dyschromatopsia, like what can you do at home? Patients may tell you, hey, when the sun sets, the red doesn't look the same in one eye as the other, or the color TV set, things don't look the same. The other thing I pay attention to a lot, if a patient's trying to get back into the clinic and they develop new onset double vision, especially on awakening, I worry about that. Occasionally you'll get a patient with a really bad corneal ulcer from their exposure. So as Mario mentioned about the pain, we want to be careful about that. The other thing which occasionally happens, which I think is a relative urgency, is the patients get eyelid popping. Their eye can't go back in because it's so proptotic. So those patients I'll try to see sooner. So did I answer the questions there, Andrea?
Perfect. Yes. So many ways that we can identify what might be a sight-threatening emergency. And then the final question in the 30 seconds that we have left here, what is the burden of disease for patients with thyroid eye disease? So more than just maybe their sight-threatening changes, what other changes happen with these patients, maybe systemically or emotionally?
Certainly, diplopia is a very important, it's a disabling situation. Maybe it is strange, and we know that then we can correct diplopia, but certainly I see more patients complaining about that sign because they can drive anymore, they can function anymore, rather than maybe complaining because their eyes are particularly protruded. So I think that is the main burden when the disease is at that stage.
And I'll give you the last word.
Yeah, there's also a lot of psychosocial impacts too, like feelings of isolation, anxiety, depression.
It's a systemic autoimmune disease and has so many implications for our patients, but I think the psychosocial aspect is oftentimes overlooked and perhaps something that we really need to look into further for our patients. Well, that ends this module, and I really enjoyed talking about this with both of you. We're going to move on to the third module. We will now start our third educational module, Diagnosing Thyroid Eye Disease, What's Involved. Thyroid eye disease diagnosis is typically made clinically based on a constellation of presenting signs and symptoms. And so we really want to find at least 2 out of the following 3 things to make this diagnosis: clinical signs and symptoms, thyroid dysfunction, and classic imaging findings. So if you have a patient that has eyelid retraction plus any of the following, you can be pretty confident that they have thyroid eye disease. So eyelid retraction plus thyroid dysfunction, most likely they have some level of thyroid eye disease, or if they have eyelid retraction and the other classic clinical findings, proptosis, optic neuropathy, enlarged extraocular muscles, and double vision. Now, if you have a patient that does not have eyelid retraction, but they do have thyroid dysfunction, and they have one of the other of the bottom list, then you can assume that they have thyroid eye disease, or at least have a high suspicion. So if they have thyroid dysfunction and classic signs and symptoms like proptosis, optic nerve dysfunction, or extraocular muscle enlargement, then they may have thyroid eye disease, or if they have thyroid dysfunction and classic imaging findings. Now, for patients that don't have these typical signs and symptoms, thyroid dysfunction, or imaging findings, then you want to consider alternative diagnoses and work them up for other conditions. Ophthalmologists can confirm a diagnosis of thyroid eye disease and can assess the activity and the severity of the disease. But this disease is typically evaluated by multiple colleagues, by endocrinologists, by non-ophthalmologists, and by ophthalmologists. So an endocrinologist or a non-ophthalmologist can do many things in their clinic to help to diagnose this disease. You can evaluate their eyelids for eyelid symmetry, eyelid position, and eyelid closure. You can look at the conjunctiva for the redness and injection of the surface of the eye. You can look at the position of their globes. Are they symmetric or are they too prominent? You can look at the movement of the eyes, and are the eyes moving properly and symmetrically? And you can evaluate their vision, check their acuity, their color vision, etc. And if there's any concern for thyroid eye disease, you can send to an ophthalmologist who will do a complete ophthalmologic evaluation, including checking their vision, their adnexa, the movement of their eyes, and looking at the periorbital and orbital structures. That leads us to our panel discussion. We're going to talk about the process for screening and diagnosing thyroid eye disease. And so again, it's my pleasure to talk to Dr. Salvi and Dr. Ng about how we can screen and diagnose. So the first question is, what is the screening process for thyroid eye disease in at-risk patients? And does screening frequency depend on the patient's underlying disease? And I'm going to give this one to Mario as an endocrinologist who sees these patients early in the disease.
Well, as already we mentioned in other discussions, but I think it's important that to ask the patient with Graves. Patients come to the clinic, they have Graves hyperthyroidism. This is, the patients with the typical patient we see. And we have to ask, do you have any eye symptoms? Because sometimes they overlooked or they neglect these symptoms. And then a very easy examination can be performed. Just make sure that the position of the head is straight, because some patients do not realize they are diplopia because they compensate by tilting their head in a certain position. So you put the patient with a straight head and you verify that the eye movement are okay and there is no diplopia in certain position in certain direction of the eye movement. It is much easier to suspect TED if you see inflammatory signs. That's certainly easier, but this is not always the case, especially at the beginning. And one thing that we have to look very carefully is there are two typical situations for us endocrinologists. One is when the disease is unilateral, when we have unilateral proptosis. There, we really have to move on to some differential diagnosis or perform some imaging because they may not be thyroid eye disease, and we want to rule that out. And the second thing is some patients do present with thyroid eye disease with no thyroid dysfunction. And this is the case sometimes of patients who come to us after going around different clinics, both ophthalmological and endocrinological clinic, and the disease was not recognized. This is usually, it's interesting because this disease is present in about 5-6% of patients with typical thyroid eye disease, and lately we see even more of these patients. So we have to really be very careful in assessing the eye for if there is presence of thyroid autoimmune disease. Sometimes the disease may associate to Hashimoto's disease, patients with just hypothyroidism, and we do perform this kind of examination to all of them.
That's fantastic. It's it's so important to work with our endocrinology colleagues to properly diagnose and manage. And how about, Ed, I'm going to ask you this question. What if a primary care physician suspects thyroid eye disease, maybe because of some eye symptoms that they notice in their clinic? Who should these patients be referred to by our primary care physicians or our non-specialist physicians? And then does the severity of the disease affect who the patient should be referred to?
Well, ideally, you'd want to refer to someone that was oculoplastic, strabismus, or neuro-ophthalmology trained if that was available in your community. And ideally, that ophthalmologist would be working in a collaborative clinic with an endocrinologist. Depending on where you are, though, like some places in Canada, the subspecialists are just too busy to do any screening, and they'll only see the patients that require immunosuppression or surgery. So it depends where your environment is, but ideally you want oculoplastic, strabismus, or neuro-ophthalmology working in a clinic with an endocrinologist, dedicated thyroid-associated orbitopathy clinic.
Great. I completely agree that the multidisciplinary care of these patients is key, and it's just important to find who manages this disease in your area and who feels like they are an expert at this disease, or they at least manage this disease commonly, and find that referral process so that you can easily refer patients. And that could be an ophthalmologist of many different subspecialties. But also we do have endocrinology colleagues that can connect with their ophthalmologist. So sometimes you can refer to the ophthalmologist who will connect you with the endocrinologist, and sometimes that works both ways. Mario, I have a question for you. What are the main differential diagnoses that you consider when you're thinking about thyroid eye disease in your patients? And what do you do to rule out other diagnoses so that you are sure of this diagnosis, perhaps before referring it to an ophthalmologist? Or do you just refer to the ophthalmologist from the beginning?
Well, I mean, sometimes certainly if I have the advantage of seeing that patient in the joint clinic, that's easy. That's easy. Because certainly when we have to differentiate diagnosis of TED, we endocrinologists cannot do without the ophthalmologist, for sure. So what I was mentioning before, certainly in the case, especially the cases that are more challenging, in which you have unilateral disease, I think it's definitely necessary to perform imaging. I mean, that is definitely the case in which that has to be done to really make a precise diagnosis. There are some situations in which patients, for example, have some other ophthalmic disease, cataracts, for example. They have blurred vision because of cataract. They don't see well. So as an endocrinologist, I would ask my colleague ophthalmologist to rule that out and to look carefully if that's really a decrease of vision that is related to thyroid eye disease or something else. So I think that when there is a differential diagnosis to be made, I think the ophthalmologist has the main role here, and it can really tell me what to do. And I think I trust doing what he tells me to do, or she tells me to do, because I certainly have more expertise in recognizing different diseases which present maybe like a TED.
So Ed, he just kicked the question over to you. So how do you rule out the different potential differential diagnoses for thyroid eye disease?
Well, a thorough history, physical exam, lab test. If you have like a mild case of TED or beginning TED, maybe you confuse it with allergic conjunctivitis or dry eye disease. When things get more advanced, as Mario and you have mentioned, imaging is essential. If you're going to order a CT scan of the orbit, make sure it's non-contrast, no iodine, and with your imaging and your clinical findings, you can rule out things like an indirect carotid cavernous fistula. These fistulas tend to have 360 episclerovenous congestion extending to the limbus. Pulsatile Myers, the patient may tell you there's a bruit. Things like orbital inflammatory syndrome are usually happening much quicker, like 24, 48 hours of redness and discomfort, as opposed to thyroid-associated orbitopathy, and usually don't have lid retraction. IgG4 disease is, we've heard more about it in the last decade. These patients may have super big muscles, but there's often lateral rectus predominance, or you might get supraorbital, infraorbital nerve enlargement. Sometimes an orbital tumor can be causing proptosis. So Mario's comment about asymmetric disease, 10% of patients with tau don't have lid retraction, so scanning is essential there. And you also mentioned, Andrea, the thing that really scares me is occasionally you'll see cases of orbital metastases with Scaris disease or lumpy muscles that really look like thyroid-associated orbitopathy. I think maybe 3 years ago, there was a case report in the New England Journal. At first I looked at it, I thought, oh, this is just thyroid-associated orbitopathy, but it's orbital metastases. And finally, because lid retraction is so common, just in the back of your mind, if the eye looks more white than it should be, could it be something like dorsal midbrain syndrome, paranoid syndrome?
So I think the points are so well taken. There are many things that can cause inflammation, pain, bulging eyes, and even double vision. And so it's so important to work with an ophthalmologist to take the onus of ruling out other diagnoses. And then, of course, we manage these patients together with many of our colleagues in a multidisciplinary fashion. And then just quickly in the last 30 seconds that we have, Mario, what biomarkers do you use for the detection of thyroid eye disease, especially early in the disease?
Well, and as you mentioned earlier on, we do not have a specific marker for the eye disease. We do have markers of autoimmune thyroid disease. And I think that if we have patients with markers of thyroid autoimmunity, I think that in an endocrine clinic, simply just play your role and just perform a very simple eye examination, because, as I say, often the disease may not present typically with hyperthyroidism, that they may come later. Patients are still euthyroid, sometimes they're hypothyroid. So the markers of autoimmunity are suggestive of a possible orbital involvement, and I think that is mandatory.
I definitely agree. The autoimmune markers and doing the clinical examination and potentially imaging can help us to get to the diagnosis. It's been wonderful talking about diagnosing and screening our patients with both of you today. Thank you so much for your time and attention. This concludes the third educational module. Thank you.